from the American Academy of Pediatrics.
1 in 5 children in the United States experiences a mental, emotional, or behavioral disorder each year, but only half of them receive the treatment they need.
We'll examine the role of med-psych units in supporting pediatric mental health.
Our healthcare systems have to do better and can do better, and I think that this is a step in the right direction.
But first, it's November, and that means it's time for a new First Up.
I think that this is a terrific example of how we can think out of the box and work with school systems and communities to try to help our children stay healthy and stay in school.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a research roundup from the journal Pediatrics.
When I think back to 2020 when the pandemic hit, I often will try to think of some good memories from that time so I don't dwell on how hard it was.
Yeah, wow. I just think of it as a difficult period of our lives. I mean, we spent more time outdoors, so there was that. And we also saw how quickly we could launch a new and effective vaccine using mRNA technology. But I think that period also opened up the floodgates of politicized public health issues that still divide us today. There was not a whole lot of good that came from the virus, COVID-19.
Definitely. We still have a lot we need to do to make sure we're communicating science clearly. And this gets to my one good thing that I'm very thankful for. All the virtual friendships that I made. Many of them were made through this podcast, and they have taught me so much. And I found comfort and friendship with you, David, and with all our avid listeners.
And also with our regular guests, like the editors of Pediatrics. And wait, it's time for a First Up Research Roundup, isn't it? Who's joining us today?
The former associate editor of digital media, who is now the associate editor of blogs, Dr. Rachel Moon. Happy November, Rachel, and thank you for coming on and for being something awesome that came out of 2020.
Well, it's great to see you guys too, and I'm happy to be something awesome that came out of 2020. This podcast it's just been a joy to be part of. And a lot of that is because of you all. And I'm just grateful that I can be part of it.
We are so grateful to have you, and it's quite the month of gratitude. And I wanted to start, since it's Thanksgiving and we're going to be eating all sorts of different foods this month, with an article on food allergies. I have a food challenge test scheduled for this month for my son. Despite being an evidence-based pediatrician and exposing him to peanuts when he was just 5 months old, we're worried about a peanut allergy. But what's been our collective experience with food allergies since the LEAP trial stressed early introduction of food allergens for kids?
That is a great question, Joanna. And I just want to remind people what LEAP is. So most of our listeners are aware, but in 2015, there was a study called the LEAP study, which stood for Learning Early About Peanut Allergy. And that has really changed how we counsel about introducing high allergen foods to children. That study showed that if you introduce peanuts early, meaning at around 6 months, to infants who are at high risk for developing food allergies, these are children with severe atopic dermatitis and or egg allergy, that these children are 80% less likely to develop a peanut allergy. So now the guidelines, which have extrapolated the LEAP findings to other high allergen foods, are that we should counsel about introducing all high allergen foods at around 6 months of age. So in 2015, the guidelines recommended introducing these foods for high-risk infants, and there are addendum guidelines that added moderate-risk infants, and now we recommend this for all infants. The question now is, has this change in our counseling made a difference in the prevalence of IgE-mediated food allergies in infants? So Dr. Stanislaw Gabraszewski and colleagues at CHOP analyzed data from electronic health records from 48 practices in the AAP's Pediatric Research in Offices settings, or the PROS network, in 3 different time cohorts. So pre-guidelines, so that was 2012 to 2014, post-guidelines 2015 to 2017, and then post-addendum guidelines 2017 to 2019. And they looked at what happened over either 1 to 2 year periods of time, with the primary outcomes being peanut, IgE-mediated allergy, any other IgE-mediated food allergy with or without atopic dermatitis. The allergy diagnosis was made by a diagnosis code for food allergy and a prescription for an epinephrine autoinjector. So what happened? So diagnoses of peanut allergy dropped 35%. Diagnoses of any IgE-mediated food allergy dropped 31% between the pre-guideline and the post-guideline groups. And then when pre-guideline and post-addendum groups were compared, the rates had dropped 45% and 37% respectively. So this is really great news. The caveat, though, is that we don't know how much high allergen foods children actually were taking in. Also, as noted in a commentary by Drs. Rushi Gupta, Lucy Biliver, and Alkis Togayas at Northwestern University and the NIAID, the National Institutes of Allergy and Infectious Diseases, these practices were all part of the PROS network. And because of that, these pediatricians may have been more likely to have been early adopters of the new counseling, so this may not be representative of clinician practice nationally. And in fact, the authors of this commentary have a separate article in this month's Pediatrics in which they conducted a randomized controlled trial to get pediatricians to counsel about early introduction of high allergen foods. And they demonstrated that 84% of pediatricians who got the training about introducing high allergen foods were doing it, compared to only 37% who did not get the training. But the U.S. is actually the only country that's now seeing a decline in these IgE-mediated food allergies. So let's keep talking about introducing peanuts, eggs, and these other high allergen foods to infants.
Well, while we're talking about allergies, we should also maybe talk about asthma. It can be so scary to watch children having an asthma attack, and if they're at school, you want to make sure they have the medications they need to help them. If schools are stocked with albuterol, does this help kids who might have an asthma attack while they're there?
Again, another good question, David. So it is super, super scary when somebody has an asthma attack, and even more scary when they don't have their inhaler, the rescue inhaler. So this happens a lot to children in school, and Illinois legislators passed a law in 2018 saying that schools should stock albuterol inhalers, have them available to anyone who had asthma symptoms and who didn't have their own inhaler accessible. Unfortunately, not many schools were stocking these inhalers on their own. So Dr. Andrea Papalardo and colleagues at the University of Illinois Chicago collaborated with the Chicago public school system to look to see whether it was possible to implement and maintain a stock inhaler program, and they started in 4 Chicago public schools. These 4 schools were chosen because there was a high prevalence of asthma among the students and because there's a full-time nurse at each of those schools. So they provided stock inhalers for the 2023-2024 school year, and they trained the nursing staff on how to use them. So what happened there? So first of all, there was incredible positive response from the school nursing staff. So they rapidly expanded the program to 302 additional schools in the second half of the school year. And the stock inhalers were used 124 times over the course of the year, and they were used at all of the schools. 2/3 of the students who used the stock inhalers were able to return to class, and only 7% required emergency services. And now there's stock inhalers in all of the Chicago public schools. I think that this is a terrific example of how we can think out of the box and work with school systems and communities to try to help our children stay healthy and stay in school.
I love that, Rachel. And speaking of being prepared for emergencies, that made me think of car seats. And I had to move a car seat from my car to my sister-in-law's car over the weekend. And I struggled a little bit. I had to find the anchors in the car, double check the latching, make sure it felt secure. I hadn't moved it in a while, and having a guide for how to place it would have been helpful. How can we help parents make sure they are using their car seats correctly?
It is so complicated to install a car seat, but we know how important it is to do it correctly. And I don't think that the complicatedness of this, I don't even think that that has improved in the last 20 to 30 years. But Joanna, obviously you know better than David or me about that. So, but the
I'm not sure. Yeah, I still struggled.
It's really hard to do. And it's reported that 80% of car seats are not installed correctly. Ideally, you want to have a certified child passenger safety technician make sure that your car seat is installed correctly. But then how practical is that? There aren't enough of these certified technicians, and most people don't have easy access to these people. So this month we have I think is an important article by David Trouble, PhD from the University of Alabama at Birmingham, and colleagues at Safe Kids Worldwide, which is an international organization dedicated to protecting children from unintentional injuries. They looked at whether a virtual appointment with a certified technician would be as good as a live on-site technician. They randomized 15,000 adults who drove cars with car seats to install a car seat with either a live technician or a remotely located virtual technician. Parents who interacted with the virtual technician did so through their cell phones. Then afterwards, an on-site certified technician uses standardized scoring protocol to assess how well the parent did, both with installing the car seat and then putting the child into the car seat. So it's really exciting because there was no difference in the virtual technicians and the on-site technicians. So the parents who got the assistance from the virtual technicians did just as well as those who got assistance from the on-site live technician. And this was the case regardless of the parent demographics or their location. So I think this is an important study. I think this is great news. Families who live in areas where these certified technicians are not easily accessible, such as rural areas or poorly resourced areas, may be able to access this type of expert assistance soon. And maybe we'll have more than 20% of children riding in correctly installed car seats.
Well, I can imagine how a program like that would be super helpful for my patients in Goldsboro. And Rachel, before we let you go, we always like to have one last moment to connect. So do you have any holiday plans you care to share with our listeners?
Well, over Thanksgiving, one of our daughters is going to be coming down, and we're just going to have kind of a nice, quiet family Thanksgiving. One thing that we often do like to do is, since we live near DC, is go into DC on Thanksgiving morning and go to a Smithsonian museum, because this is a not very well publicized fact, but the museums are open on Thanksgiving all day. And so we will often go to a museum that we've wanted to go to for a while, but haven't gone to because of the crowds. And there are very, very few crowds. And you can just look at things at your leisure and enjoy the museums.
Well, now it's going to be wall-to-wall pediatricians. So
I think so. Now that I've announced this to how many, 15,000 pediatricians, maybe we can have the AAP meeting there on Thanksgiving Day.
That sounds like a lot of fun to be hanging out with other pediatricians on Thanksgiving. Dr. Rachel Moon, we are so thankful you were able to join us today, and we hope you enjoy the holiday.
Thank you so much. It's been great to be with you again, and I hope you all have a very nice holiday.
For these articles and more, visit our website at aap.org/podcast.
Coming up, we'll look at the role of med-psych units in promoting pediatric mental health.
David, we've talked before on the podcast about the issue of children with psychiatric diagnoses staying for weeks or months in the emergency department or on the pediatrics floor. Are you seeing any improvement where you work?
Well, North Carolina has been working on opening more capacity for these patients. I'd say it's improving a little. Most commonly, we're managing the complications of, for example, a suicide attempt, and then hoping we can find an inpatient psychiatric bed once patients are medically stable for transfer. I remember one young person in particular who has type 1 diabetes, and because of their suicidality, we could not allow them to use their home insulin pump, and that made glucose control just so much harder.
I imagine that must have been a huge challenge. And so we should make some space on the podcast to talk about how hospitals are trying to meet this need.
Well, then we have to talk with Dr. Andrea Hadley, a MedPeds hospitalist and division chief of Pediatric Acute Care Services at Corewell Health Helen DeVos Children's Hospital in Grand Rapids, Michigan. She has just been part of opening a med psych unit there and can give us some insights into pediatric mental health and what communities can do to help. Andrea, welcome.
Thank you so much for having me. I'm excited to share our work on this topic and hopefully help other health systems think about some solutions for the patient populations that they are seeing.
You know, I think so many communities would love having pediatric medical psychiatric units for their families and children. When did your community start working on this idea?
So our hospital, just like all children's hospitals across the country, really started to see skyrocketing rates of hospital visits, ER visits for mental health crises. And especially during the triple-demic, when we had COVID, RSV, and influenza all surging at the same time, the pressure that was on our healthcare system for pediatric acute care beds, it really highlighted that our pediatric mental health and behavioral health patients were becoming really stuck in our healthcare system, not getting the resources they needed. And also we had competing need for those beds for our acute medical patients. And so that was around 2022, 2023, when we started to really feel that pressure and realize that our community needed this resource.
And speaking of resources, I think a lot of pediatricians would love this for their community, but they worry about things like getting funding to start it. How did you guys get that in order to accomplish this goal?
Funding for this project was complicated and definitely came from multiple sources, including philanthropy, including capital investment from our healthcare system, as well as some state involvement in the funding.
I imagine, in addition to funding, you confronted all sorts of other institutional barriers to get this program off the ground. What do you think were the biggest challenges in getting this going?
The biggest challenges for this project, I think, were one, the facilities and construction of the facility. So the physical space, that is space that has to be safe for patients from a behavioral health standpoint, ligature resistant, and that is expensive equipment. And then also adequate for providing the medical care. So those two things can be at odds. So finding the right space and then the staffing. So the expertise in staffing a unit like this requires staff that have training in both the psychiatric management as well as the management of medical issues. So thinking about even the nurses at bedside, handling both the medical needs of the patient as well as the psychiatric needs of the patient. This is a highly skilled staffing model and difficult to develop, recruit, and retain. And then the other big challenge has been working with the insurance companies and the financial stability of the unit itself based on the complexities of mental health insurance coverage with mental health carve-outs. This required us to work with multiple different insurance programs, negotiations, single case agreements, and that is very complex.
So give us a better idea of what it looks like now in this unit, who's on the teams that round, and who's working directly with the patients.
So this is a 12-bed unit. We have patients with a variety of medical and psychiatric needs. Up to 40% of the patients can be straight psych and 60% med psych. So we do have a mix of patients with both psychiatric and med psych needs. And then the staffing includes our behavioral health techs, our nurses that are, again, trained in both medical and psychiatric skills. And then we have our behavioral health team with our therapists, our psychiatrists, and then we also have our pediatricians, our hospitalists that are involved in the medical care of these patients, our social workers, and many other team members who are working on that floor.
And how do you get these diverse groups of team members to communicate effectively about the complicated care for these patients?
Communication is key. So we start the day with a daily rounding huddle at 9 a.m. We discuss all of the patients on the unit, both from a behavioral health standpoint and a medical standpoint. And we develop plans together in a multidisciplinary approach that includes all of the team members, even for patients with eating disorders that obviously dramatically impacted by the dietitian on the unit as well. So a very multidisciplinary group coming together each day.
And you mentioned eating disorders. Are there other sorts of patients that you've been able to serve on your unit that you would not have been able to help otherwise?
I think that this unit does provide a location to treat some of the most medically complicated patients with both developmental and cognitive disabilities who also tend to have severe autism, who have seizures, and those patients are historically very difficult to place elsewhere. So we've been able to provide care for those patients, as well as the eating disorder patients, patients with diabetes that you mentioned as well, complicated patients with trauma and injuries who have ongoing physical therapy, occupational therapy needs, who may have, for example, fractures and casting or pins in place that are still requiring daily medical care of their injuries that can then start their psychiatric healing at the same time.
And what sort of response have you had from your community and from the medical community with the creation of this unit?
That's a great question. We have been this year purposefully working on strategies to increase the outreach and referral base to the community so that now that we've been up and running and working on improving, perfecting our care flows and our work on the unit, trying to strengthen those ties with the community to be able to share the great work that we're doing and increase our referrals. Definitely, there's a lot of interest out there with the increasing number of these types of patients who are in the community.
And Andrea, I feel like a lot of people listening to you right now are going to be like, we need a unit like this. If they want to get started on one, what direction would you give them?
I think some early steps would be to reach out to other hospitals who have similar units. We did that at the beginning and went and shadowed multiple times and learned about existing units. And then, of course, forming that multidisciplinary team to dig in, to do the community assessment, to look at the certificate of need that needs to happen early on. And so forming that multidisciplinary team of experts who can come up with the plan moving forward is key.
And we are super excited about this program, and we're hoping to see more like it across the country. But before we let you go, do you have any last takeaways for our listeners thinking about this?
I would like to highlight that the need for services for this patient population is there. The current model of psychiatric care does not meet the needs of all of these patients. We are seeing increased complexity, medical complexity, increased chronic illness in our patient populations, and the traditional models of behavioral health don't meet the need for these patients. And so there is a need, and our healthcare systems have to do better and can do better. And I think that this is a step in the right direction.
Well, it's certainly a big step. And Dr. Andrea Hadley, we want to thank you so much for joining us today.
Thank you so much for having me.
To learn more about the Pediatric Medical Psychiatric Unit at Corewell Health, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Okay, I know so little about football that it's actually a running joke between you and me and our friends and my family.
Go Birds.
My son is at
Sorry, you mentioned football. I live in Philadelphia.
I love birds. They're beautiful. So my son's school is doing really well in football, and he's all into it. So he went to a game last Saturday in the afternoon, and it happened to be while I was at the gym. And it was on. at the gym. So I kept texting him and sending him pictures of the game. And I had to stay on the elliptical for like 45 minutes because it had so many timeouts and ref calls. But like, he is drawing me into football now, and we are connecting over these games. And it's just a lot of fun.
Is that the game where there are 8 innings, David, the football?
No, 3/5.
Sounds good. Go Birds again. So my say is not about sports. It's about the fact that I did a Monday date night with my partner, Danny.
Whoa.
And it was so nice. We stumbled into some free babysitting and were able to just go out on our random weeknight. And it is just really nice to connect with your partner and get out of the house and spend 2 hours just being together.
Oh, that is a true say. Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss a new toolkit to support school health information sharing.
We'll talk to one of the contributors, Dr. Heidi Schumacher. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.